So welcome to virtual curriculum at UVA. This is our 7th night, and so I appreciate everybody who's been participating in this. It's been a lot of fun for all of us. So tonight it's our pleasure to highlight the adult reconstruction division. I think we're gonna have a lot of fun hearing from Dr. Thom Brown, who's been basically doing this. You know, he helped train me back when I was a resident as well, and was actually the program director at one point. So he kind of knows what I get to go through. And then after that, Alyssa is going to do a case presentation about a periprosthetic fracture. And at the end, Max Hoggard, who is one of our PGY-5s, one of our administrative chiefs, is going to go over mentorship here at UVA and how he chose a fellowship, and just kind of give you some tips as far as how to navigate the residency process and how to look for mentors and how to get a good fellowship and where you're going to go from here. So looking forward to that wisdom. But without further ado, I do want to introduce Dr. Thom Brown. Again, Dr. Thom Brown is a legend of these parts. He coined the term ARTHROPLASTY here at UVA, and basically has tackled every single complicated problem I've ever seen amongst joint replacement cases. He makes a simple knee look easy. He makes a complicated knee look easy. He makes a simple hip look easy and a complicated hip look easy. But some of my best and favorite cases were as a resident with Dr. Brown. So tonight he's going to talk about periprosthetic fractures around total knee arthroplasty. Dr. Brown, is my screen being shared? Can you see it?
Yes, I can.
All right, very good. Well, I'm going to shut up then and let you do all the talking, but you tell me when to advance the slides. Dr. Brown's PowerPoint in his house isn't working too good, so I'm going to do the PowerPointing for him. So you let me know when to advance the slides and we'll go from there, okay?
All right, sounds great. Thanks, Winston, and welcome to everyone who's signed in tonight. And first off, I want to congratulate Winston on getting this whole process started during these highly unusual times for everybody to allow some education to happen when it can't be face-to-face, which we all would prefer. But this is the next best thing. I'm going to go over a little bit about fractures around total knee, but I want to, next slide, but I first want to congratulate everyone that is contemplating orthopedic surgery as a specialty. Believe it or not, I was in your shoes 30 years ago to the day of looking into orthopedics as a specialty and looking at programs, trying to decide where to go, and it's been a wonderful ride. It is a very challenging profession, physically, psychologically, emotionally, and it truly is not for the faint of heart. You don't have to be a gorilla, but you do have to have a strong heart to deal with it. It is an incredibly rewarding, albeit humbling job. Every one of us experiences humbling moments during our career, even to this day. It's you have a great impact on patients' lives in terms of what they can do following your intervention upon them to make their lives better, and it's incredibly rewarding. And it's a lifelong commitment to doing this. Again, I'm still waiting to do the perfect operation. I have not yet done it, and I may never actually do it. And I want to give you all, the best of luck and hard work to fulfill your dreams to be in this situation. As Winston mentioned, I've been here. I'm kind of the old guy now in faculty, which is hard to believe. I've been here a little over 20 years, and I've trained over 100 residents and over 35 fellows. And I think probably 8 or 9 of our faculty that we currently have now that I had the opportunity and privilege to train. And I'm hopefully that some of you that are tuned in tonight, that I'll have the opportunity to help you on your journey as well. All right, next slide. Before we start on the talk here, just a little bit about our division. Right now, we have 3 full-time joint replacement surgeons. There's another Dr. Brown, who's the division head and vice chair of clinical operations. And then there's Dr. Quay, who is the vice chair of research. We are actively recruiting for a 4th surgeon, so I would imagine that any of you that would match here next year, that we may be up to 4 full-time surgeons. It is a metal and plastic rotation, primary and revision hip and knee arthroplasty. We have the dubious distinction of having the largest revision burden in the state of Virginia. So we have lots of transfers, which honestly, and the residents can tell you, can get a little bit painful because we're always inheriting problems generated from other facilities. Prosthetic joint infection and periprosthetic femur fractures, failed hip and knee dislocations, et cetera, et cetera. In terms of how the service works, we have 3 PAs. Each one of them kind of works with 1 attending. We have 2 fellows who are integrally involved in resident and med student education. And 2 residents work with us at a time. So we have a PG-2 and a PG-5 working with us right now. And coincidentally, it's Alyssa and Max who are on service presently doing a great job. And Liza now as our intern is also doing an outstanding job taking care of patients on the floor. So the PG-5 also covers our ortho-oncologist who works with us 1 day a week. So he's with him in clinic in the morning and then operates with him in the afternoon. And the PG-2 covers the emergency room call all day Wednesday. So essentially Monday, Tuesday, Thursday, and Friday is all total joints. So either in clinic or in the operating room, taking care of patients. A very busy inpatient service, complex primary knee, computer-assisted surgery. We're hoping to add robotics in the future. Direct anterior total hip, and again, all the other miseries and nightmares that go along with arthroplasty. All hip fractures that require arthroplasty we take care of, so there's plenty of opportunity to be involved with hemiarthroplasty and total hip arthroplasty for that growing patient population of geriatric femoral neck fractures. Our division has been very productive, and much more to the kudos to the other Dr. Brown, Dr. Quay. Last year, 28 peer-reviewed publications. So the residents and fellows have ample opportunity to get involved in some good research while you're there, which is an important component if you're interested in pursuing a fellowship following residency. Next slide. Here's the crew here. I'm the tall guy in the middle, and Dr. Brown to my right, to left of the screen, and Dr. Quay, who was also one of our residents and fellows that I had the pleasure to train. Next slide. All right, we're going to talk about periprosthetic fractures around a total knee, and this is a huge topic, and obviously we're not going to cover everything that's related, but it really boils down to 3 bones. Okay, you have the femur, which is by far the most common. We're going to focus on that. Periprosthetic patella fractures can happen, and those are rarely operative unless you lose the ability to extend your knee. And then lastly, tibial fractures, which is the center x-ray you can see there. Very rare, thankfully, because they're also very difficult to treat. So we're going to focus on the femur. Next slide. So when you're looking at any x-ray, and this can involve a shoulder, a knee, an ankle, anything where there's hardware or there's a replacement and something's gone wrong, you have to answer these questions. And this is important that you think about this both in terms of taking care of patients and also in answering questions on the orthopedic in-training examination and on your board exam at the conclusion of your residency. And the first one is or was the implant stable, and was the implant working and well fixed prior to the fracture? And that's a question that's going to be very important to figure out, so you can kind of come up with a menu for your treatment options. Next, is there any signs of loosening or failure of the implant on the fracture films? Anything that might suggest that perhaps the knee replacement or the hip replacement, whatever it might be, is not well fixed in the bone, because that changes the treatment plan radically. And then thirdly, and anytime someone has a painful joint replacement, again, anywhere in the body, is there any prior history or is there concern for infection? So people that if they come into clinic, everyone is infected until you prove otherwise, okay? And then a very simple start is a SED rate and a C-reactive protein, which can give you some good information. Doesn't tell you why those numbers are elevated, but it's helpful to get that as a baseline, provided somebody hasn't fallen and broken a bone. Also to ask people about their joint replacement. How long were they in the hospital? Was it uncomplicated? Were they on antibiotics? Did they have any drainage? All those things, you have to do a little detective work to figure out what's going on, and is there something that's been brewing for years that finally reared its ugly head? The best x-ray is an old x-ray, all right? So whenever you have the opportunity to look at an x-ray from before, it's very helpful to determine, has there been a change in the position of the implant or something else that suggests that maybe it's not well fixed anymore. All right, next slide. All right, so we're gonna talk here about supracondylar femur fractures. And again, these are by far the most common, and you will all see tons of these in your careers, because there's about 1 million total knees going in every single year. And a million people don't die a year. And these people are getting joints in their 50s and 60s, and assuming that a joints last 20 or 30 years, you can see the numbers expand rapidly and radically. And fractures are going to occur from usually ground level or low energy injury. Occasionally we see these from car accidents, but again, the vast majority of these are ground level falls. Next slide. So what are the risk factors? So why do people get broke? Why do people get fractures? So there's some systemic things, osteoporosis, and this can be medication induced, plain old age, females that have not been appropriately supplemented with calcium and vitamin D, etc. And the other issue is, how steady are you on your feet? So if you have a seizure disorder, ataxia, Parkinson's disease, history of stroke, cerebral palsy, any type of neuropathic joints such as diabetes or myelopathy, some cervical or issues with your central nervous system that can affect your ability to walk normally and end up falling. And the more times you fall, the odds go up that you're not going to get up from one of those falls. There's also some local issues. Now, when you put on a knee replacement onto a femur, we're focusing on the femur, is that the bone that's right behind the metal is shielded tremendously. It's like being on a space shuttle. Okay, so the bone is much softer just because it's being shielded from the normal stresses that it receives. So this bone also becomes very important when you're trying to treat these injuries, if you're trying to fix the fracture and trying to preserve a joint that had been working well prior to the injury. Any type of revision surgery, malalignment of the joint, osteolysis, you can see on this x-ray here on this slide that of all the lucency around that tibial component and the cement there, and the bone has just kind of been eroding away for years until it just kind of failed. Thankfully, we don't see as much of this as we used to, because the polyethylene or the plastic that's used as the articulating surface in joint replacement is now being manufactured in a way that it's much less prone to develop osteolysis, but nonetheless, it still does occur. Last thing I want to mention is notching. So if any of you have ever scrubbed or seen a total knee replacement, the implant is sized from top to bottom or anterior to posterior on the femur. And if the component is too small and you cut for a size 5 and you should have cut for a size 6, you can notch the anterior cortex of the femur. And if that notch is big enough and deep enough, that becomes an area where the bone can fracture from some type of stress on the bone. Next slide. Now, operative treatment. Now, anything in orthopedics, you have to think about, what's my menu? How am I going to, what are my options to take care of this problem, whether it's a fracture or a disease or something else? And again, this is not to make light of it, but you have to, there's a lot of things on the menu that may not taste very good, but you may have to consider those because you may not have all those options available. You may not have all the implants that are required, or your hospital may not be prepared for it, or you could be in a third world country and you may not have the implants that you need. So you have to know all the various ways that you can treat a problem. Now, with total knee fractures or supracondylar fractures like this, that the days of traction are long since gone. That used to be a viable option of putting people in split traction, trying to treat these. Now, the goal is to get things stabilized so that people can be mobilized quickly, minimize time in the hospital. And the days of having somebody in the hospital for 4 to 6 weeks are long since gone. So if these are going to be treated operatively, you have to try to attain fixation such that the joint maintains its alignment, so the joint continues to work well if it was working well before, and also to minimize the risk of knee stiffness. If you immobilize somebody for a long period of time, you may get the fracture to heal, but you also may lose a lot of motion in that process. Next slide. So in terms of fixation, so if we've looked at an x-ray and say, yep, the implant was working well, the patient had very little or no pain prior to their particular injury, and now it's broken, and now you've got to figure out how to fix it. So there are 2 major categories: a retrograde nail or a plate. And retrograde means starting from distally and working proximally. And both these have had good success. And we'll go through some of the pros and cons of each of these before discussing what do you do if the implant is not well fixed. Next slide. So retrograde nail, it's an advantage. So it's, it's an intramedullary device. It's something that's become very, very heavily utilized in orthopedics to take care of long bone fractures and even some fractures that are near a joint. And supracondylar periprosthetic fractures are no exception to this. So the advantages of retrograde nail is that you get to essentially use the same incision that was used for the knee replacement. And then you're avoiding devascularizing the fracture, and you're basically spanning the fracture with a titanium nail that has interlock screws both above and below the fracture. And it can provide good stability, allow for early mobilization and good healing. Next slide. Now, the disadvantages are that it's not applicable to all knee implant designs. So you see on this X-ray here, this happens to be a revision knee. And if you look at the femoral component, there's a stem which is cemented up above there. So obviously the canal is not available for an intramedullary device. There are other primary implants where there is an opening, we call it an open box. It may be a cruciate retaining knee or a posterior stabilized knee in that regard, and that's in relation to whether or not there's a posterior cruciate substitution built into the implant. And some of these have a hole or an opening that will allow you to pass a nail through the knee replacement up into the femur to stabilize the fracture. Other implants may be too small or have a closed box, so it's important to know what you're dealing with so that if you decide you're going to try to do a retrograde nail, that the implant that you're trying to pass the nail through will accommodate such a device. Next slide. Disadvantages and this really applies to both nails and plates, is that the money bone that you have to deal with is the bone that's basically contained within the U of the femur, so to speak. So on the lateral X-ray, that bone that is kind of contained by the femoral component has undergone significant stress shielding, may be comminuted, and that's the most important bone for providing distal fixation or stabilizing the fracture distal to where it's broken. The bone up in the shaft is readily available for the most part, unless there's another implant coming from above, such as a total hip replacement. But the distal part is challenging. Next slide. So here's an example. So it's, again, technique is a midline incision, and you can either split the patellar tendon as you would for a tibial nail, or you can go median parapatellar as you would for a knee replacement or a knee revision. And you're trying not to disrupt the blood supply to the fracture site. You're trying to reduce this indirectly, and then interlock the nail both above and below the fracture. You can see the screws are kind of passing behind the femoral implant distally, and then you see 3 interlocks up above. Now, the difficulty with this is that, especially in older patients, that it's not like nailing a femur in an 18-year-old that has a very tight canal with excellent bone. The nail is very snug in there and really keeps things well aligned. So oftentimes, there's a lot of room inside the canal in elderly patients, and it's very easy to malreduce this and end up with a leg that's in a considerable amount of valgus, and patients hate it, and the knee replacement does not work as well. So and you have to really be very critical of your reduction during surgery before you start finalizing your fixation with your interlock screws. You're trying to avoid a severe valgus or knock knee deformity. Next slide. So here's an example of if you look on the far right X-ray, that's a cruciate retaining knee, and I can tell that by looking at you kind of see the metallic portion of the implant, that there's no box or anything, and so there's an opening there to allow that nail to pass in, and the fracture has occurred. You can see there's some good, it's kind of an oblique fracture, and there are interlocks that are passing through the nail and through the fracture right behind the implant, which is stabilizing it. And they did a good job of aligning the total knee and also providing good stabilization to facilitate healing. Next slide. Now we're going to talk about plates. And I think plates have really become far more popular, and that's also because of the the technology that's become available. And it's actually been during my career. I mean, locked plating was something that was introduced during my early part of the career when Dr. Chhabra was one of my residents back in around 2000. And then what I mean by a locked plate is that normally when a plate is applied to the bone, the plate is being held to the bone by the friction of the screws that are compressing it across the bone. A lock plate, the screws actually lock into the plate itself, and they provide excellent fixation in crappy bone. And that's exactly what we're dealing with in a lot of these periprosthetic fractures. So you have many more screw options down in that area right behind right inside the femoral component, which greatly increase the stability of the fracture. And again, we use plates all the time, upper extremity, lower extremity, foot and ankle, you name it. So plates are used all the time to treat long bone fractures, especially periarticular injuries. So we're usually fairly familiar with that. And this has become became an extension of that routine practice. Next slide. So a disadvantage of the plate is that, again, for the same thing I mentioned before, is that if the bone is comminuted and it is stress shield or disuse osteoporosis in that region, if you can't get good fixation, you can't stabilize the knee, you're going to have a poor result. Secondly, if you open up the entire fracture, in other words, you make an incision along the lateral aspect of the knee, and you strip everything off there so you can look at it directly, you're asking yourself for a non-union because you've disrupted a lot of the biology that has started the healing process in order to put your plate on. So we're trying to avoid doing that. So a lot of plating that is done now is done via indirect reduction and without looking directly at the fracture site. Next slide. So this X-ray here on the right is something you don't want to see this. Whether you're dealing with a supracondylar humerus or elbow, as you stripped everything on both sides. The plates are relatively short, and this we call this a dead bone sandwich. And this has a great, very high propensity to develop a non-union if it doesn't get infected. So this is what we're trying to avoid when we're using these locked plates. Next slide. So again, this is a picture of a locking plate, and the plate is already pre-contoured. So if you are able to reduce the fracture indirectly, and the angulation that the plate has built into it inherently will allow you to put the bone right back where it belongs. You don't necessarily have to be looking directly at the fracture. If you can get the plate up against the bone distally and proximally, and then suck it down to the bone itself, you can get an excellent reduction without disrupting the biology of the fracture. Next slide. So the advantages I mentioned is fixed angle, and what I mean by that is that the screws are fixed to the plate, so it's a fixed angle, so you get good fixation and bad bone. You have lots of screw options. You have 5 or 6 screw options available for most manufacturers' plates for this purpose in that distal bone right around the femoral implant. And there's a lot less disruption of the periosteum and the blood supply, so the biology of the healing is much better. Next slide. Now here's an example. This was actually one of the first plates, and I had the dubious distinction of having the largest number of these implanted when it first came out in the years for this. It's called a LIST plate, which stands for less invasive surgical stabilization. Now every country, this is a Synthes product, and every company that makes fracture implants now has some device similar to this for almost every bone that you can think of. So the incision, this is just to orient you. This is a right femur. It's a little bump under the knee to flex the knee a little bit to help reduce the fracture, take the pull of the gastrocs out of the equation, try to get the fracture reduced in a closed fashion. Then you're making a lateral incision. This plate is just slid up along the lateral cortex. You fix it provisionally both distal and proximal to the fracture, make sure it's reduced and looks good on orthogonal or 90-degree views, an AP and a lateral view. And once you're sure of that, you put in your hardware to stabilize it. Next slide. Here's a schematic here that, again, with just making small incisions distally, and then you make small percutaneous incisions to apply the screws through this outrigger to make sure the screws go where they belong. It really makes these injuries fairly straightforward to take care of. There's less blood loss. less morbidity of filleting open the leg all the way, from the knee all the way up to the mid femur, and get great stabilization in the process. Next slide. So here's an example of a supracondylar fracture, and you can kind of see from the lateral view, which is the one on the left side of the left X-ray. The bone appears to be well fixed. You can see the cement haze there. There's no obvious signs of loosening of the implant. Tibia component looks okay, best we can see. So we're treating this as a stable, well-working implant. And next slide. So this is a fluoroscopic view of plate has been slid up along the lateral cortex. And you say, oh boy, they didn't do a very good job. Look at all that gap between the plate and the bone itself. That's inconsequential because, again, these screws are locked to the plate itself. So the plate is almost serving as an internal, external fixator. And this, again, allows you to stabilize a fracture. You have not disrupted the blood supply and give this a very good chance of healing in an anatomically reduced position. Next slide. Again, you can see here, this is a little bit later on, kind of a close-up on the medial side, and you have not stripped the blood supply off this bone, and the bone has a much better chance to heal, and all that fuzziness around there is essentially callus that's forming because of reducing this in an indirect fashion and not disrupting the biology, which is so important to get these things to heal. Next slide. Now, lastly is probably the one that's probably more dramatic, but thankfully for me and for patients, that it's not one that always has to be done. And that is, what do you do if you have a fracture around an implant that is not doing so well? It's either infected or it's loose or it's unstable or something. And now you're looking at a situation and say, is there any way that we can fix the fracture? Or are we wasting our time doing that if the knee replacement is functionally useless to that patient? So now we have to think about, are we going to be able to kill two birds with one stone, so to speak? In other words, we have to put in a new knee replacement and also deal with a fracture at the same time. Next slide. So the technique, again, these are big surgeries. These usually require long stems that bypass the area. If you do have some condyles remaining, trying to capture the condyles with the implant, and allograft was used liberally in trying to reconstitute some of the bone around these bad fractures. And I'll tell you that in my career, I have done one of these utilizing allograft. So I think it is something that people realize that it is, it's not terribly successful. It's sexy to talk about, but not something that's practically used on a routine basis. Next slide. So the vast majority of these, and this is kind of similar to perhaps the femoral neck fracture in an elderly patient, is that we're essentially throwing in the towel. We're saying, look, there's no way we're going to get this bone to heal. If the implant's not working well, why don't we just remove the fracture from the equation, take a saw, remove some bone, and then replace the knee with a hinged replacement. And what I mean by that is that, this device that you can see on this X-ray substitutes for the medial collateral ligament, the lateral collateral ligament structure, the posterior capsule, everything. So this will, you don't have to worry about whether or not the MCL or other ligamentous structures are available to help with it. And so it is, again, it is an option, but all these options come at a price. And I'm not talking about the cost of the implant. I'm talking about the cost of longevity or durability, because the more constraint that you put into a joint replacement, and again, I don't care if it is a knee, shoulder, hip, ankle, the more constraint you put into that device, the shorter its lifespan will be, because the way it's fixed to the bone will be stressed tremendously compared to an implant where you're relying on the ligaments. I'm going to make a bold prediction that in the next 15 or 20 years, there's going to be a rash of failed reverse total shoulders, because the constraint built into that device to take care of a rotator cuff deficient shoulder. Again, it's a great operation, has revolutionized the care of bad proximal humerus fractures and arthritis with really bad cuff rotator cuff arthropathy. But that constraint will rear its ugly head in the future in terms of loosening of the implants, in my humble opinion. Next slide. So here's an example of a periprosthetic fracture following a plating. In other words, this is a non-lock device that was utilized for a supracondylar femur fracture, and the fracture, actually a new fracture occurred below where the fixation ended. And this is, we call this a stress riser. In other words, wherever hardware ends and bone begins, that is an area that is subject and prone to fracture. So we try to avoid having stress risers that can result in a fracture. Always thinking about that, where a plate ends or where a rod ends, and the impact or the ramifications of that construct. And here is, again, so this is a second time failure, and the surgeon here said, I don't think I can fix a fracture because it's so distal. The bone has already been compromised some by the fixation from the first fracture. So the hardware was removed, the distal femur was removed, and now a hinged device is cemented in place so that the patient essentially is ready to walk on this on post-op day 1. Next slide. So in conclusions, again, we have some new technologies. The lock plating has really become the mainstay of treatment for these, although retrograde nails can also be utilized, and allows you to get fairly good fixation while respecting the blood supply and the biology of the fracture to give it a better chance to heal. And I think, a revision total knee is only if the implant has failed, and ORIF, or open reduction internal fixation, it just isn't possible. And again, this is not a common occurrence. I mean, I've probably done over 10,000 joint replacements, and I think I have done less than 50 of these distal femoral replacements for periprosthetic fractures. The vast majority usually have enough bone that will give the fracture and the patient a fighting chance of getting the bone to heal without doing an operation that has a very dichotomous outcome. What I mean by that is either a home run or it's a horrible failure. And what I mean by that is that we're always concerned about infection. And in the best of circumstances for a primary knee in a healthy person, the infection rate is less than 1%. And that is a healthy person, good soft tissues. And when you're doing something like this in a knee that has just exploded from a fracture, with fracture hematoma, inflammation that has occurred in there, the skin is tough, that's the worst possible time to be putting a joint replacement in, honestly. And so if you do it and it's successful, they love you. But if it turns out that you develop a deep infection, it could result in an above knee or transfemoral amputation, and that's no worse feeling than that, to give somebody that bad news that there's nothing that can be done. And I think another point when we're talking about infection is that it's not just losing the limb; it's losing your life. I mean, the 5-year mortality rate, okay, from an infected total joint, and the treatment that is rendered to try to get rid of that infection. The 5-year mortality rate is 20%. So 1 in 4 people will not survive 5 years after the development of an infection. So it is a sobering statistic, and that's why we are so diligent trying to avoid infection, because we do a much better job of preventing it than we do of treating it and eradicating it. Next slide. Any questions at all on this? Again, remember, there are no stupid questions, just stupid answers provided by me.
Dr. Brown, that was outstanding. Every single time I snip out a little bit of meniscus, I always think about the stuff you're doing in the next room. I feel kind of silly taking that little biter and getting a tiny little fleck of meniscus out, knowing that one day it might all just be metal.
Hey, this is Dr. Chabra. Thom mentioned this, but I was a senior chief resident when he was a fellow, and we started on faculty together. And it came through some difficult times, but from learning as young attendings. But you can all see that he has consistently been one of our top educators for 2 decades plus, and he's our fellowship director for joint replacement. He's been our residency director in the past, and he is without doubt, he is not scared of anything when it comes to joint replacement. Everyone in the state sends him every complication, and he's not scared of anything. And his surgical skills are remarkable. And he mentored the 2 other joint surgeons in our department. And he's obviously, you can see how great of an educator he is. But he made a point that we have a very busy primary practice, but we take care of a large burden. Almost 70% of the failed joint replacements in the state come to UVA. So it's a very, very busy service that is growing. And then I talked about Ivy Mountain a couple weeks ago. So you see that Ivy Mountain will have a big focus on primary joint replacement as an outpatient or 23-hour stay. So Dr. Brown is absolutely remarkable, one of the best surgeons in the country, and one of the best educators as well. So, and he has consistently done it for over 20 years. So we're very fortunate to have him part of our team, and you'll be very fortunate if you end up here to learn from him. So, and this is the first time I've sat through, like last week, sat through a full spine or joint replacement lecture in a few years. So it was great.
You're learning some stuff, Dr. Chabra.
I'm learning stuff. Yeah, exactly. Thanks, Tom.
Those are bigger incisions than you're probably used to, aren't they, Bobby?
Yeah, a little bit. So, but I'm going to sign out now. But it was great, and thanks again, Tom. And I hope everyone's enjoying this remarkable curriculum that Dr. Guathme's put together.
All right, Alyssa.
Thanks. Words, Bobby.
Alyssa's going to share a case with us, okay? And there might be some type of interaction. So, like we did last time, if you guys want to raise your hand, go ahead and raise your hand, and then introduce yourself and tell us where you're from, and maybe even turn your video on if you'd like, and we can go through some questions, okay? All right, Alyssa, go for it.
So kind of the second part of our talk will be a case presentation, and then Max will go through the mentorship and resident life talk after this. So our case tonight is a lady who actually came into the ED about 3 or 4 months ago. She was a 64-year-old lady. She fell over her dog at home. She comes in, she tells us that she, I don't need to unmute myself. I think I'm unmuted. She said that she has pain about her knee. She wasn't really able to walk after the fall. She tells you a little bit more about her history. She said she had her initial right knee replacement done in the early 2000s. She's had multiple revisions since then. She was last revised in an outside hospital in 2004 to a varus valgus constrained prosthesis due to instability. You don't necessarily have the records, but this is kind of what she was telling us in the ED. So when you go examine her, let's see. She has a BMI of about 56. She was tender palpation over the right thigh and knee, but that's about all you can appreciate. And she didn't necessarily have any open wounds. She's neurovascularly intact. When you examine her hip, she doesn't really have hip pain, and her pulses are intact. So kind of looking back into her records, you find that she had 1 x-ray in our system, and this is an x-ray from about a year prior after her most recent revision. And she had come for kind of a second opinion on what to do. So this was kind of one of the first places that we were going to stop and just talk about.
Anybody want to raise their hand? Just look at this x-ray and just kind of tell me what you see. To see what's out there. Don't let me call on you. Yeah. All right. How about Rob Turk? I see Max Hoggard. He wants to put his hand up. All right, there's Rob. Go for it, Rob.
Sorry, I was muted. Hey, everyone. Yeah. So here we have 2 views: a lateral of a right knee, which shows total knee replacement, and the thing that sticks out obviously is the lateral, which the femoral stem of the knee replacement really looks like it. You said this was when she came to the ED, or these were previous?
So these are actually, yeah, good question. These are actually before she came to the ED. So she had shown up in clinic once before, and these are the x-rays that were obtained in clinic before she came to the ED.
Okay. And so, yeah, I mean, it's concerning because it looks like there's essentially no lateral wall or lateral cortex left for that femoral stem. So that's concerning. And then In terms on the tibial side, you do see, I think, stress shield and the reaction to tibial the stem is probably pretty well.
Yeah, those are all good points, Robin. So when you look at this X-ray, so again, so this patient, she was wheeled in a clinic, but this is before she ever fell. And obviously we have an implant that's failing. So this is what we call a press fit stem. In other words, the stem is kind of used to provide some adjunct fixation for the soft bone around the knee. So the implant has started to come loose down towards the joint line. And over time, the femoral stem has slowly migrated its way from inside the femoral canal to outside the femoral canal. And again, she was seen in my clinic, and she has a big sign on her forehead that says "Don't operate on me," based on how bad her health is. A BMI, if anyone that has a BMI over 50, it's kind of like you have a 50-50 chance of having a disaster by operating on somebody that's that large for lower extremity surgery, be it hip or knee, primary or revision surgery. So we made a decision at that point that she had to do something to improve the chances of her getting through an elective procedure, and that involved weight loss, bariatric surgery, something to give us a fighting chance of being able to help her and not end up with an amputation. And you can see how well that decision turned out, that she ultimately was trying to ambulate around her house and fell over a dog. And the story continues.
So then you're in the ED after you see her. You decide to get x-rays, and this is what you see now.
Anybody want to tackle that x-ray? Sorry to call on you guys, but how about you, Brian Shear? You're up there high on the alphabetical list.
Yeah. So looking here, obviously we have an AP and a lateral. You mentioned a press fit stem. The other question I was going to ask, is that a hinge knee in there at this point? Or what's
looks like it, but it's actually we call it a varus valgus constrained knee. So it does provide a little bit of extra support, but it will not suffice if you have complete MCL incompetence. So it does provide, so you have a big box that goes into the groove in the femoral component that gives you some support, but it still relying on native ligaments.
Gotcha. Thank you.
Good pickup.
And then obviously the big thing that we see here is the periprosthetic fracture. Looks like it on different sites for this. And it looks like the stem might not even be femur at this point.
Right. So again, so now this is kind of the slow migration has now been supplemented by rapid migration out the rest of the way out of the femur. And we've got so we have a loose femoral component. The tibial component, as you can see from some of these x-rays and also from the ones that Alyssa showed before, that the tibial component appears to be okay. So now we're faced with a dilemma of, now we've got a lady that can't mobilize or ambulate at all, who is a terrible operative candidate. So what are we going to do now? It's kind of hard to tell somebody to lose weight when they can no longer move because of pain and stuff. So now, my hand has been forced. And now we're looking at, how are we going to treat this problem? This is when sometimes the items on the menu are not so tasty. We got to figure out what are we going to do to stabilize. Can we stabilize this, or do we have to do something to eliminate the fracture from the equation and revise it to like a distal femoral replacement with a hinge type device that Brian had mentioned before.
So going through specific challenges of this case, we can talk about her bone quality. So as you guys have probably already seen, she has pretty poor bone quality. Another thing that Dr. Brown had mentioned is that she has poor fixation around the implants. So if you look back at her implants here, you can see that the femur is not well fixed. And then the last thing, which Dr. Brown had mentioned in his talk, talking about poor blood supply. So those are other considerations that you have to think about when you're either going to plate, nail, or replace. So considerations in the perioperative period is one, the location of the fracture. So you did a nice job about explaining where the fracture was, the stability of the component, and the presence of the bone stock. So at this point, this would be another point where what are kind of the options that we could do for?
Yeah, let's, I think we're gonna try to keep this under an hour, so let's just keep moving through maybe.
Okay, we only have one side left. So last slide.
Maybe Max the answer. You can maybe call on your chief. You phone a friend.
Not the way, no. But so what we ended up doing for is a distal femur replacement because she had poor bone quality. The implant was not well fixed. She's a BMI of 56 and she's actually doing pretty well today.
Yes, this is a couple comments about the X-ray here. So that this, this implant, as I mentioned before, that when you use a hinge replacement, especially for fracture, that there's a very high rate of loosening. So this is actually a biologically fixed hinge up above. So if you look at the femur as you work your way up, you see that there's a couple cables around the bone, and there's actually, it's called a sleeve, and this sleeve has porous coating on it. So we're trying to achieve biologic fixation, similar if any of you have seen a hip replacement that uses a femoral component. This is like an upside down femoral component that's wedged into the femur that will hopefully get biologic fixation, and hopefully this thing will last more than a half dozen years before it comes loose again, because this lady is putting a tremendous load on this, and thankfully that her wounds healed up and she did not develop an infection, so we got lucky here. But it just as easily could have turned into an absolute nightmare for everyone involved had she developed an infection from this intervention. Any questions or comments from the gallery?
That was great. My only comment to everybody out there is that we do primary joints here too, primary hips and primary knees. So I don't want to scare you and think that distal femur replacements are going to be a standard surgery we do here. Although it certainly makes for cool x-rays. Dr. Brown, how many primary knees and hips do you think we do here as a program?
I think right now, between the three of us, I think we do between 12 and 1,300 joint replacements a year, and I would say probably about 1,000 of those are primary and about 200 of those are revision or fractures or other complications that require arthroplasty. And obviously with Ivy Mountain opening, will be, our volumes will go with another surgeon and also another venue in which to operate. Certainly that it's going to go up quite a bit over the next 5 years.
I mean, I think there's a lot of value in the revision setting as well, but just learning why primaries failed, or, and helping you to refine your technique and refine why you do what you do. But there's no question the future of orthopedics will be joint replacement just by virtue of how our population is aging and the needs. So a very valuable thing to have in your skill set. So Dr. Brown, Alyssa, that was fantastic. I really do appreciate you guys putting all that effort in.
Thanks, Winston. Appreciate it.
Yeah.
Dr. Brown, it's Nicole. Can I ask a question?
Yeah.
For that patient, you always mention ruling out infection. Obviously, her ESR and CRP are probably elevated given the fracture. Do you get an aspiration beforehand or send cultures intra-op?
I did not, because at least I had the luxury of seeing her. I actually was probably a month or two before we had done the full workup at that time with an intact femur, and her labs, her ESR and CRP were stone cold normal at that time. So I did not aspirate her beforehand. But that's a good point. That if someone has any type of trauma, or if you had the flu, or you fell off your bicycle, or anything can cause your sed rate and CRP to be up. So you can't rely on that entirely to determine it. So any person that comes with a broken bone and you get those particular labs as part of your workup, those are going to be elevated and really not give you any, specific information for why they're elevated. So an aspiration to look at the number of white blood cells and the differential of those white blood cells in the aspirate can be invaluable in trying to help you make that decision. Are you dealing with a joint replacement that has had a low grade or chronic infection or something, because that may change your treatment drastically.
Great stuff. Well, thank you, Dr. Brown. Nicole, great question.
We've got a
Max?
question. We've got a question from Joshua here.
Go for it.
Hi, Dr. Brown. Quick question. So obviously with the distal femoral replacement, if this patient was to go on and have chronic infection and she did not want an AK, because you mentioned before, 50% of the time, distal femoral replacements get infected. Is there anything you could do to salvage this if she really doesn't want an AK? Because obviously an AK is such a serious.
Yeah, it's just a great question. So yeah, I mean, there's always more metal, and so if you have an infection like this, and I've dealt with this particular problem where you have to do a two-stage revision. You have to explant all of the infected metal, put in some type. It would obviously be a non-articulating spacer, so you basically span the defect with usually with a femoral nail that's been coated in antibiotic cement, keep the leg out straight treat them with antibiotics, and then come back with more metal in the future. And the other advantage of that biologic fixation on that femur is that if it were to become infected, we're not digging out 8 inches of cement that runs all the way up to the lesser trochanter. So that allows for relatively easy explantation and still have a fair amount of femur left for replacement. And again, you can replace the entire femur, and you can have a total hip that's attached to an entirely metal femur that goes down into a hinged knee replacement. So there are options. Now, whether or not that would be advisable for a patient that has a poor prognosis for being able to clear the infection is another topic, but it certainly can be done.
Okay, thank you.
You're welcome.
All right, Max, you're up.
All right, everybody hear me okay? Thankfully mine's quick. It's tough to follow that, but I'm gonna talk a little bit about kind of our mentorship model that we have here between the residents and the residents, so resident mentorship and then resident faculty, and then a little bit about how that applies to kind of choosing a fellowship. So so upon matching, so all the interns are paired up with one of the PGY-4, so one of the rising PGY-4s. And so the pictures here are the current 2s and the current chiefs that were paired up last year. And I think that relationship is it's a good one to kind of start. And I think, Dr. Gwathmey was instrumental in kind of setting this up, and I think it works well. Because as you, as an intern, kind of graduate and become a PGY-2, you're paired with a chief, and so that works a lot in a lot of different ways. Primarily, the second years are taking a lot of the call, and so you have a kind of a personal or a familiar relationship with the chief that you're oftentimes staffing consults with and working with on the weekends and whatnot. So I think that is one advantage of how we kind of set up our mentorship within the residents. But also, I mean, it can kind of be whatever residents decide they want it to be. So Neil is my mentee, and so we talk a lot about rotations, what's kind of expected, things that I experienced when I did them when I was a PGY-2, and I try to give him tips on things to avoid, how to not look stupid like I did as a PGY-2, and so kind of give him kind of a leg up on kind of going through the PGY-2 year, which is classically a little bit tough. It also works well for kind of picking up study habits, because that can be kind of a challenging thing, because I think learning and studying and self-learning particularly is a little bit different in residency compared to medical school. And I personally thought it was helpful with kind of getting plugged into some research interests. So it's tough to come up with research ideas on your own, especially as an early PGY-1 or 2, and tough to find projects as well, unless you kind of know what you're looking for. They're there, and I think the senior residents can kind of help the younger folks kind of get dialed into that stuff. So I don't know if any of the current PGY-2s are here that want to add anything to that. I know we're running short on time. I can keep moving otherwise, but.
Well, take your time, Max. You're doing great.
Neil or Alyssa or anybody want to add anything?
Well, if I could make a comment, I was kind of behind this whole process. My fear was the moment you matched into your residency program, it was exciting and all, but then you're like, well, shoot, well, like all the questions you might have and whatnot, you might not know who to go to. And so I wanted to establish a formal relationship with somebody so that you at least know that it's okay to ask questions and get some guidance. Where do you live? Like, if I have kids, like where do you put them in daycare? Do I have a pet? Just questions like that. And then I was hoping it would evolve over the course of your intern and PGY-2 year to ask more like, I guess, questions about career stuff and things like that. And so that's kind of like the goal behind it. And in my experience, some residents have needed it more than others. Some residents really don't need it at all or don't utilize it at all. But I just wanted to be there in the event that you needed that kind of guidance, or at least hope to have that kind of guidance. And so that's my 2 cents. Okay.
Yeah, this is Neil. I'm on the call. I think kind of reiterating everything Max said. He's been a great resource for me, and somebody I feel like I can always go to with questions. As far as helping me to not look stupid, I think Max is fighting an uphill battle there. But overall, I think it's a great program, and echo everything that Max and Dr. Rothby said.
Yeah, and I think having a resident, and then you're also paired up with a faculty member as well. So I think you're really set up for success in that regard. And, I think people can, take as much advantage or little advantage as they want of it. I think certainly some of the stuff you wouldn't feel comfortable, just approaching, you match and there's, 30 attendings or whoever, you may not have met any of them before. So it's tough to approach some of them. Potentially you could be intimidated or whatnot. So I think having a faculty mentor that's kind of assigned to you, it works well. And so these are all attendings that have volunteered to do this. So they have an interest in mentoring. And so my mentor was Dr. Abel on the far left there. And I remember we went out and had pizza like the first week I was here, and fortunately I'd met him when I rotated here, so I kind of knew what he was about. I think if that had been my first interaction with him, I may have regretted my decision coming here. But he's been awesome. He's kind of an intimidating guy, as everyone knows, just because he's has a little bit of a military background. But he was awesome. Just kind of he's kind of big into the food scene and all this stuff, so he can kind of get you oriented in that regard. But I think in general, we have met a couple times, at least over the course of the intern year into the PGY-2 year. And it's really another resource that can kind of help guide expectations as far as transitioning from a medical student into a resident. And it doesn't necessarily have to be pegged with any sort of, fellowship interest or subspecialty interest in the first couple years. And I think that works well. And so Dr. Abel obviously is a pediatric guy. I'm not going into peds, but it works just the same. So you can see the other mentors here that were paired with other folks. I don't think anyone's actually going into the subspecialty of their mentor, at least in the chief class, but it works well. And so that evolves that faculty mentor or faculty resident mentorship kind of around the PGY-3 and 4 year, when you start to think about what you want to do, what subspecialties you're interested in, what fellowship you're thinking about doing. And so this is kind of how my personal experience has evolved. So I went from kind of Dr. Abel first couple of years, and then Dr. Gwathmey knows pretty well. I had a tough time choosing what I wanted to do ultimately. And so I talked to him a lot. I talked to Dr. Dacus and Dr. Chauber a lot about, what I wanted to do, like what I liked, and they kind of helped me pare some stuff down. And once I kind of had a little bit of better grasp on that, I was able to kind of gain some mentorship from our trauma division, Dr. Weiss and Dr. Yarborough, as well as Dr. Thompson, our oncologist. So it's nothing really assigned or formal as kind of your as you progress as far as mentorship goes. It's kind of based on what you're interested in. And some people know what they want to do, and are fortunate enough to kind of have that already in mind as they go through it. I was kind of the opposite. I didn't know what I wanted to do. And so I think the availability of attendings to be mentors really helped me. Otherwise, I'd still probably not know what I wanted to do. So it can kind of morph in that regard. And I think that's, a particular, advantage, I think, of having attendings that are willing to be such great mentors. But kind of transitioning into fellowship. And so I think, as a PGY-3, by the end of that year, you've been on every service at least once. And so you get some experience of whatever subspecialty, maybe what it's like. I think you also go to Roanoke, so you get a little bit of the kind of the private or private-demic setting, so not necessarily a pure academic setting, so you can kind of get some flavor of that as well. I think generally, aside from me, this is when most people kind of decide and start paring down what they want to do. And so, like I said, I think most people just reach out to that faculty member that's here, whatever subspecialty it may be, kind of around that time, and they can kind of reach out and figure out, okay, where are good places to apply, then kind of essentially touch base about, where previous residents have gone, where the attendings might, have connections at other institutions, kind of talk about whether they want to do academic or private stuff. So this here is a list of our previous fellowship matches. And so I think every subspecialty is represented within the past 4 years, I believe. Obviously we send a lot of people to sports and hand fellowships, but Dennis matched into adult recon this past year, and then Siraj the year before that, and I expect we'll have two of our PGY-4s matched into adult recon fellowships this year. So I think that's well represented. We've had people going into spine, people going to peds. 2 or 3 of us have gone into trauma. So I think we've shown that we've got a wide variety of people that get good training in pretty much any subspecialty, and I think they go to good fellowships. If you look at some of the places listed there, I mean, it's, some of the top places in the country that you'd aspire to go to. And I know within, at least within my class, I think everyone got either number 1 or number 2 on their list, as far as I know. So I don't know. I think that speaks to the training we get, but also to the mentorship we have from the attendings here that I think put us in a good position to be successful as far as that goes. So just to kind of wrap up, this is sort of the timeline of everything I talked about. And so basically you match, and you're paired with a faculty mentor and a PGY-4, it becomes a PGY-5. And then kind of that transition period where you find a mentor that's within your subspecialty, and that kind of transitions and helps you in the fellowship process. And then before you know it, you're becoming a mentor to an incoming resident, which is kind of a cool thing, kind of coming for a full circle. So anybody else wants to add anything? That's all I've got from that aspect, but I think it works well. I think it shows that you look at that fellowship list of places we've gone, I think we've got a good kind of system to help people get where they want to get and do what they want to do. So open it up for questions or comments from anybody if they want to add anything.
Great job, Max. I mean, at the end of the day, it takes a village to, train our residents and get them where they want to go. And mentorship doesn't just happen during your medical school years, your intern year, PGY-2 years. I'm still being mentored by folks like Dr. Brown and Dr. Chabra and my other faculty. And honestly, orthopedics ends up being such a small world. It ends up being a big family. And the UVA family, I feel like, is such a powerful, strong connection to everybody. So I hope we've been able to demonstrate that with these different talks we've been doing and just kind of the relationships we have amongst each other. So Max, awesome job. And it's exciting to see. I mean, it's crazy. I remember when Max was a rotating medical student, and here we are. He's about to go to a trauma fellowship in Greenville. It's very exciting. So it's so cool on our side of it to see this. And that's why people like Dr. Brown and myself do what we do, and Dr. Bachman, because watching medical students who can hardly, suture become outstanding surgeons is really what makes, what makes me excited. So great job, Max. Any other comments from anybody else? We're a little bit over time, but I think this is an important topic. So if anybody has any questions, please ask. Or anything to add? Alyssa, have you got a lot of the mentorship program?
Yeah, no, I've actually really enjoyed it. And I think Max made a good point that while you're paired with a formal mentor, I mean, Max has been a great chief for me on service. I've actually had him as my chief twice. And I think as a junior resident, you really look up to the chief that's on your service. And we have a great class of chiefs this year that have really kind of taken ownership over making sure that us as junior residents feel supported. So it's not necessarily always a formal mentorship, but I think kind of the expectation of this program is that the chiefs kind of take ownership of it. And because of that, they've really helped us, especially through our first early call months, because we've definitely needed it. So we appreciate it. But yeah, the mentorship is great here from resident to resident and attending to resident. So
yeah, and I completely agree that the informal mentorship, I think, is going to be much broader and much more comprehensive than the formal. It's just that as a PD, I want to make sure we set up at least something established so you feel comfortable having somebody to go to, and then it will evolve from there. Awesome. Well, so I just we'll close this session tonight. We have one more divisional session. We're going to highlight the trauma division. Orthopedics, a lot of what we do is fracture surgery. And so next week we'll have the trauma service close out sort of the didactic portion of this. Our final week will be a resident forum where basically you can ask our residents whatever you want. This coming Thursday, Dr. Bachman and I are going to carve some time out of our schedule and meet with each of you guys individually. So expect an email either tonight or tomorrow morning with a sign-up sheet to meet with us individually. So if you have specific questions for us. So with that, I'm going to say thank you to Dr. Brown, to Alyssa, and to Max for putting all this together, and another outstanding night. These are a lot of fun for us, for me as a sports guy, getting to hear all these cool topics. So I've actually enjoyed this a lot myself. So I will see everybody next week. Thank you, Dr. Brown.
Thanks, Dr. Bachman.
Thanks, Winston.
Adios.